now move on of the third presentation with François Stéphane, that we manage the patient in pre-oxygenation and intubate. We manage it optimizing ventilatory intraoperative setting. And now what happened after this procedure, after extubation, after surgery? François will propose us some recommendation.
Thank you, Samir. So high flow has gained popularity, and now it's based on many randomized clinical trials. This is one of the first clinical trials. And remember, in the post-operative management, you can have two different strategies. One strategy is a preventive strategy, and the second in the curative strategy. This is one of prophylactic strategy in medical patients with about 1/3 of surgical patients, and this Spain team compared high flow with conventional oxygenotherapy. And as you can see in this curve, the conventional therapy has an increased rate of reintubation after extubation compared with high flow oxygen therapy. And this is in low-risk patients, and the low-risk patient, it's a young patient under 65 years old without major comorbidity like COPD, cardiac insufficiency. The same team performed again a prophylactic strategy, but in high-risk patients. High-risk patients are older patients above 65 years old with COPD, cardiac insufficiency. And it is a non-inferiority study, and as you can see, the result is negative. It's a non-inferiority. The non-inferiority is demonstrated during the first 24 hours, and after you have an increase in the complication rate. In the post-operative setting after cardiothoracic surgery, again, you have the result of RCT study in a preventive strategy. And the results are a little bit disappointing because you have no positive effect on oxygenation in two studies, and maybe you have a reduced requirement for escalation therapy in two studies. And in the last study, as a preventive strategy, after thoracic surgery, you have a decrease in the occurrence of hypoxemia and the less reintubation rate, and a decrease in the need of non-invasive ventilation. After cardiothoracic surgery, you can also apply a curative strategy. This is one of the first studies performed by a French team in Nantes, and they have compared standard oxygenotherapy with high flow, and high flow provide a better PEF ratio, and they also demonstrated a decrease in the PaCO2 level. This is, in this study, we compared high flow with intermittent non-invasive ventilation in the non-inferiority study after cardiothoracic surgery. More than 800 patients were included, and the results were that the BiPAP provides a better oxygenation, the PaCO2 level and the respiratory rate improve more quickly with high flow, the relief of dyspnea and comfort were similar. High flow provides the ease of application and a lower nursing workload. At least in preventive strategy after major abdominal surgery, the team of Emmanuel and Samir performed this elegant study, and the choice of the primary outcome was the occurrence of hypoxemia 1 hour after extubation. And so they apply high flow compared with conventional oxygen therapy. And this is again a negative study in such a preventive strategy because you have no difference for the occurrence of hypoxemia. But when we saw the recruitment of escalation therapy, maybe there a tendency to a decrease in the escalation therapy. So high flow for all, certainly not, because there are some patients who did not respond very well to high flow in terms of improve oxygenation or decrease in the respiratory workload. So finally, high flow has now several potential indications based on randomized controlled trial. There are limited data of COPD, but trials are ongoing. And so maybe we should combine high flow with non-invasive ventilation, and also trials are ongoing. There are some positive effects and or outcomes that are now sustained by physiological data. But some uncertainties remained. The wide variability in inclusion criteria, the primary endpoints, physiological variables, intubation rate, mortality, and the choice of the comparators, standard oxytherapy, non-invasive ventilation, and if you choose non-invasive ventilation, the mode of delivering this non-invasive ventilation, helmet, face mask, nasal mask, or the total facial mask. Thank you.
François, thank you very much for this nice presentation. It's very interesting, this last data coming from this new therapy. Just to start, could you give us your advice or your clinical practice? I'm for an anesthesiologist who is not an expert. Could you give us how I start? I start with high flow, with high FiO2, the real life, please,
Okay.
of your practice.
So the first one is when you decide to provide high flow, you need to set the temperature.
Ah, okay.
What the main point is to set the temperature before to apply the device. Okay. Because if you apply the device without temperature, it's very difficult for the patient to tolerate the high flow. So the first is set the temperature before to apply the device. The second is to...
Please, just the value of
the
range of the temperature for the majority of the patients.
So it's between 34 degree and 47 degree. The recommendation in 37 degrees. However, some recent data by the Mori team demonstrated that lower temperature could be more acceptable for the patient. So I cannot give you precise recommendation, but in my practice, I set on 37 degrees.
Okay, this is clear.
And if the patient did not tolerate well, this temperature will decrease the threshold. But some team began to 34 degrees, and after they increase the temperature. I think that the two ways are correct. So the second is to set the flow, and the minimum of flow is 30 liters per minute. Below 30 liters, you have no physiological effect. You have no advantages regarding the work of breathing, the clearance of CO2, so minimum setting is 30 liters per minute. And I think the best is around 50 liters per minute for tolerance and efficiency.
Okay, and about the FiO2, you said
so
to obtain, you have a target objective of oxygen saturation?
Yes, I think the objective is oxygen saturation around 92%.
Okay.
Not above. 92%, I think it's correct.
It's very clear and pragmatic. Thank you, François. Emmanuel.
François, yes, just one question. In your clinical practice, do you replace finally standard oxygen therapy by high flow, or do you still use conventional oxygen therapy?
Yes, when we read the data from Gonzalo Hernandez, conventional versus high flow in prophylactic strategy, it's very impressive data. However, the rate of reintubation in conventional therapy is quite high, even in surgical patients. So, for patients without major comorbidities, without without hypoxemia, we still use conventional oxygenotherapy. And in case, for some patients with risk, like patients with hypoxemia after extubation, or for a patient with cardiac insufficiency, COPD, we provide the high flow for this type of patients. But in usual practice, the first in conventional oxygenotherapy.
Yeah, very important to keep this in mind. Yeah, and the second point is about patient location. Do you think we can perform oxygen therapy using high flow device in area other than high dependency care unit or ICU, or is it possible to do that in a conventional surgical ward, for example? Or what do you think about that?
Yeah, now there's some data about the use of the high flow device in surgical ward, but you need to provide information, and the paramedical team should have a skill to monitor this device, because it's not the device to admit a patient in a surgical ward or in the ICU. It's the clinical state of the patient. This is the major point. So why not to use high flow in surgical ward? Even you could provide a good monitoring of this patient.
I have one probably last question for both you, François and Emmanuel, of our colleague Thierry. Why it's a bad thing to give too much oxygen during perioperative period, as Emmanuel told us, and then over-oxygenation has no limit in post-operative period? Good question.
Yeah. So I think there are now a couple of data to not provide so much oxygen in patients. So, however, we need to deliver a sufficient amount of oxygen in patients, because the final goal is to provide oxygen to the cells. So I think for the high flow, for example, the threshold of 92%, I think it's correct. We don't set the high FiO2 to give oxygen saturation around 100%. It makes no sense. But around above 92%, I think it's correct.
Yeah, I fully agree with you, François. There are a lot of data showing that hyperoxemia is very dangerous for the lungs, dangerous for the heart. It's very dangerous for the brain. So we don't need to have too much oxygen within our bodies, and it can be very dangerous for patients to have high inspired oxygen concentration. So again, we have to change, and we need to change because commonly we applied 100% oxygen concentration both during surgery, in the ICU, in medical and surgical ward, and again, it's not the right thing to do that.
Yeah. And one other comment, the main problem is sometimes not the medical team, but the nurse team. Yeah. Because sometimes nurse, they learn that 100% is better than 92% of oxygen saturation. And so sometimes your patient is very well with 90% of oxygen saturation, and the nurse increase the FiO2 to provide a 100% of oxygen saturation. That's a big problem now.
François, thank you. Emmanuel, thank you about this, Audrey.